Hi, this is Gisela Dewald from Maryville University discussing my doctoral project, Reducing Indwelling Urinary Catheter Utilization and Duration, a Quality Improvement Initiative. My committee members include Maryville University's Dr. Amanda Flynn, my chair, and Dr. Stewart, the second reader. My community member was Bethany McDowell, the infection control nurse at the facility. The question guiding research: will modifications to the electronic medical record, the EMR, reduce utilization and duration of indwelling urinary catheters within critically ill patients? Intervention included modifications to the current nurse-driven protocol within the EMR. The Agency of Healthcare Research and Quality AHRQ recommendations were added. Utilizing alternative methods as a first-line intervention were recommended. Indwelling catheters could be placed for hourly volume measurement needed to guide and direct therapy. Specific recommendations included life-threatening lab abnormalities, hemodynamic instability, frequent titration of inotropes, vasopressors, or diuretics, etc., ongoing fluid resuscitation, and acute hypoxic respiratory failure requiring a FiO2 greater than 50%. The problem is that urinary tract infections are the most common healthcare-associated infection, or HAIs. About 75% are associated with indwelling urinary catheter use. The risk of developing catheter-associated urinary tract infections, or CAUTIs, are associated with prolonged duration of indwelling catheter use. The risk increases by 5% for each day, and they have the highest occurrence amongst critically ill patients. National quality improvement initiatives recommend decreasing CAUTI rates by decreasing inappropriate utilization and limiting device days. A nurse-driven protocol was implemented by the institution in 2019. However, it has been ineffective with nursing staff often copying and pasting or dragging and dropping previous documentation without truly reassessing the need for continued indwelling catheter use. Benchmark values were 63% at the beginning of the project. And although CAUTI rates are not of particular concern for the institution, indwelling catheters do increase the risk of developing these healthcare-associated infections. There is no reimbursement for these infections. They are estimated to cost an additional $137,963 per CAUTI. The cost of patient life, complications, and increased length of stay associated with CAUTIs can also be substantial. Culture is the most common barrier to implementing measures to decreasing urinary catheter use in the critical care setting. Typically, the belief is every critically ill patient requires an indwelling catheter. After all, critical illness is an appropriate indication provided by the CDC, correct? Wrong. Critical illness is a vague term. It is open to interpretation. Clearly defined indications for critical care use are needed. Appropriate assessments are essential to prevent undue harm to the patient, prolonged hospitalization, neglect, injury, or complications. The aims for this project included improving adherence to guidelines for appropriate indwelling catheter use, creating clearly defined definitions for critical care indications, reducing overall indwelling catheter utilization and duration, achieving national benchmarks of about 30 to 36%, improving patient safety and outcomes, and creating a culture transformation within the critical care setting. The literature review noted 4 main themes to reducing indwelling catheter utilization and duration. It is estimated that 21 to 52% of indwelling catheters are placed for inappropriate reasons. Developing clearly defined appropriate indications for use, such as the CDC guidelines, facility-specific criteria, or the AHRQ recommendations used in this project, are necessary to reduce indwelling catheter utilization and duration. The number 1 overuse indication is urinary output monitoring. Remember, urinary output monitoring is needed to guide and direct therapy for an indwelling catheter placement to be appropriate. The facility already uses the CDC guidelines as appropriate indications, but the AHRQ and MEDICS recommend specific critical care indications to clarify use. Using appropriate methods to avoid and reduce indwelling catheters is supported by the literature, but no particular method is recommended over another. The consensus seems to be a variety of methods should be available. The most important takeaway is that they can help avoid indwelling catheter utilization by 73 to 100% just by using alternative methods as a first-line intervention. Once an indwelling catheter has been placed, the duration of use is the most important modifiable risk factor. Ensuring awareness of the device through the nurse-driven protocols, EMR reviews, or a variety of tracking options to promote device removal are supported by the literature. Determinants of nurse-driven protocol include factors such as usability, misalignment of workflow, institutional policies, perceived lack of provider support, and perceived risk or complications associated with compliance. Each of these factors were considered and addressed during the project development. The theoretical framework for this project was the Translating Evidence into Practice model, initially created by Pronovost et al. In 2008, but later evolved into the Johns Hopkins Quality and Safety Research Group Translating Evidence into Practice model. This is a collaborative model designed for large-scale knowledge transfer to create organizational change, which is what I intended to do with this project. There are 5 main components and 4 phases. The model improves reliability through the concepts of the 4 E's: engage, educate, execute, and evaluate. Engagement promoted ownership of the project by sharing stories, estimates of harm, and current data values. By providing current national standards for utilizing indwelling catheter use in the critical care setting and our current ranking values, staff were promoted to improve engagement and ownership of the project. Education was used to disseminate the evidence-based practice guidelines provided by the AHRQ. These guidelines help create a unified definition of critical care indications for appropriate use. The execution was completed by implementing a standardized modification to the nurse-driven protocol intervention throughout the entire organization. The modifications of the nurse-driven protocol within the EMR encouraged avoiding indwelling catheter placement by utilizing alternative methods for urinary output monitoring and only placing an indwelling catheter for the specified AHRQ indications, which indicate that hourly volume output is needed to guide and direct therapy. A culture transformation was required to adapt to the new guidelines and challenge the traditional utilization of indwelling catheters. This is a quantitative quality improvement project using retrospective data to evaluate outcomes. The National Healthcare Safety Network, NHSN data, was used to evaluate utilization outcomes because these data values are what predict benchmark values. Data collected from the retrospective chart review, the EMR, was used to evaluate duration and other secondary data about the intervention modifications. The intervention is aimed at reducing indwelling catheter duration once the device is placed, so data gathered about duration and specific criteria for the intervention help to evaluate its effectiveness to impact change. The population included a convenient sample of all adult critically ill patients provided in the table on this slide. The intervention includes edits to the nurse-driven protocol within the EMR to include specific critical care indications for indwelling catheter use. Their intervention also created a hard stop, requiring nurse to select a specific critical care indication before saving their documentation. The pre-intervention group is from February 1st to May 31st, 2021, and the post-intervention group is July 1st through October 31st, 2021. Please note the 1-month implementation period. The outcomes included primary outcomes of utilization and duration, and secondary outcomes to evaluate the effectiveness of the EMR edits. The convenient sample was gathered from 2 sources, the NHSN database and the EMR review. It included all adult patients greater than 18 years of age admitted to the critical care unit with a urethral indwelling catheter placed during the study period, regardless of diagnosis, gender, ethnicity, or demographic factors. Every indwelling catheter within the organization is reported to the national database. Data is gathered at 7 a.m. daily, and input is completed by the infection control nurse. Indwelling catheters are organized within the database by unit locations, such as critical care, labor and delivery, medical floor, etc. No exclusion criteria apply. If a urethral catheter is in place, it is reported. Archived data retrieved from the NHSN database included all information pertinent to the facility's urinary catheter use, limited to the critical care unit. EMR data was gathered from a retrospective chart review. The EMR data was collected from a list of patients admitted to the critical care unit during the study's time frame. Each EMR was evaluated for inclusion and exclusion criteria included on the slide. If any exclusion criteria were met, the chart was closed and no data was collected. Data analysis was completed with the help of Maryville statistician Dr. Pauls. This project was a comparative quantitative research design utilizing pre- and post-intervention data to determine if utilization and duration were reduced. Primary outcomes were evaluated with data from the NHSN for utilization. Utilization was recorded as how many catheters were used. These values are provided as ratio values, which included those with an indwelling catheter divided by the total number of ICU patients. These values provide accurate comparison for utilization in each group. A z-test, a difference of two proportions, were used to evaluate for statistical significance. Secondary outcomes were evaluated with data from the EMR, particularly for duration. Duration included the numerical value for catheter days. To determine which test was needed to evaluate statistical significance, the data had to be assessed for normality. The data did violate the assumption of normalcy, so a non-parametric Mann-Whitney U was performed. The 6 questions on the right of the slide were used to evaluate the intervention and described using descriptive data points, particularly frequency. Figure 1 shows the data trend line from data gathered from the NHSN. As you can see, there was a reduction in utilization and duration which occurred throughout the project. Table 1 includes data retrieved from the NHSN. The utilization and duration of devices were lower than the predicted value provided by the national database. The predicted value is an assigned value that accounts for variability across differing facilities. The standardized utilization ratio, or SIRS value, is a risk-adjusted measure that allows for consistent comparability over time and across entities. Table 2 shows the output for the z-test, the difference of two proportions. The average proportion was 0.4859, noting insufficient information to suggest that utilization decreased between the two groups. Table 3 and 4 show the input data and calculation outputs for the z-test. Figure 2 shows comparison data from the EMR review and include the total number of patients, those without indwelling catheters, those with an indwelling catheter, and the duration of device use over the course of the study. Note the number of those without an indwelling catheter exceeds those with an indwelling catheter for 5 of the 8 months. Table 6 includes data findings from the EMR review. Table 7 includes one sample Calvagova test, the normality testing, indicating that the values violated the assumption of normalcy. Table 8 and 9 show the output information from the Mann-Whitney test, indicating that the difference in duration was statistically significant in the post-intervention group compared to the pre-intervention group, with a z-score of negative 3.065 and a p-value less than 0.002. Analysis and results. In the pre-intervention group, 14% of indwelling catheters were placed without an appropriate indication. 6 indwelling catheters were placed without an order. 6 were placed with an order but without an appropriate indication. 40% were placed before arrival. 43 of those placed in the operating room or the procedure room. 7 at outside facilities. 12 in the ER. 8 were chronic, and 34% were not removed when indicated. The average duration was 3.64 days. In the post-intervention group, 8% had no appropriate indication. 6 indwelling catheters were placed without an order. No indwelling catheters were ordered without an appropriate indication. 33% were placed before arrival, with 30 of those in the operating room or procedure room. 6 at outside facilities, 6 in the ER, 6 were chronic, and 25.8% were not removed when indicated. The average duration was 2.89 days. Overall, the project was able to decrease these values in the post-intervention group compared to the pre-intervention group. There was a 33% reduction in duration, which was statistically significant, a 4% reduction in utilization with no statistical significance, a 6% reduction in benchmark values, 29% if you count the pre-study. Current benchmark value is 34% with a national benchmark average of 30 to 35%. There was a 6% reduction in those placed without an appropriate indication, a 7% reduction in indwelling catheters placed before arrival. The ED decreased their placement by half. There was a 9% reduction in those not removed when indicated by the protocol, and avoidance of indwelling catheters were noted with an increase in the number of patients without an indwelling catheter. Strengths and limitations. Strength, the culture change, the excellent guiding coalition, the ease of implementation, addressing barriers, and the sustainability of the project. For limitations, the study period, I would change the time frame for the study to include the planning data values, as there seemed to be a correlation between the project progress through the DNP program and the values of indwelling catheters. Utilization may have shown a statistical significance if those values were used. Variation in data sources. Due to the retrospective nature of the study, it was often difficult to discern if the indwelling catheter counted towards the ICU or medical unit, particularly if the indwelling catheter was not removed before discharge from ICU status. Often, patients remained in the ICU as medical floor patients due to limited bed availability and staffing shortages. This made data collection a bit more challenging. Another issue is the NHSN data output was provided as quarterly data. The study period for the project did not include all months of the quarter, so this did create a little bit more work to remove the non-pertinent data. Appropriate nursing documentation created a barrier as nurses were completing the intervention before the device was removed. If the intervention was not manually added back to the work list, then documentation was missed. The timing of the intervention was at 6 a.m., which falls on the night shift to remove the device. Night shift staff rarely have face-to-face interactions with providers and rely heavily upon the previous shift's report and provider documentation to stay abreast of each patient's plan of care. If documentation or shift report is lacking, the nurse may not feel comfortable removing a device in fear of making the wrong clinical judgment. After all, the doctor will be around soon. Generalizability is both a strength and a limitation for this project, which is why the bubble crosses both fields. The population was limited to the ICU population only, but this particular critical care unit services a variety of specialties. The project included every adult patient admitted to the ICU with an indwelling catheter during the study period, regardless of diagnosis, ethnicity, gender, or demographic factor. The intervention is one format, so changes were distributed throughout the organization, helping create an organizational change. It is no surprise that utilization was not found to be statistically significant. The intervention addressed indwelling catheters once placed. To affect utilization, the intervention would need to address indwelling catheters before placement. Although education was aimed at avoiding indwelling catheter placement and promoted the use of alternative devices, education alone was not sufficient enough to create a statistical significance in the reduction values. Similar findings and barriers were found within the literature. By clarifying appropriate indications, 3 studies were able to decrease utilization from 10 to nearly 30%. Similar barriers found in the study cited indwelling catheters placed before admission and nursing compliance with nurse-driven protocols as barriers to reducing indwelling catheter use. Another noteworthy finding of the project was the change in culture achieved within the intensive care setting. Patients without an indwelling catheter increased throughout the study and exceeded the number of patients with an indwelling catheter for 5 out of the 8 data collection months. This is a massive win for the intensive care unit. The culture is no longer consistent with traditional beliefs that everyone in the critical care unit needs an indwelling catheter. Although specific data was not collected regarding alternative devices, one can infer that these values increased as indwelling catheter usage decreased. The project met study goals even if statistical significance varied. Aims to improve adherence to guidelines, improve safety and outcomes, create a culture transformation, and reduce utilization and duration were achieved by the study. The long-term goal of reducing indwelling catheters by greater than 30% within 1 year was achieved by the project in record time. Benefit to practice. This project challenged the traditional culture of the critical care setting by avoiding indwelling catheter use and reinforced new guideline recommendations that urinary output monitoring does not require an indwelling catheter for all critically ill patients. This project highlights the positive impact that quality improvement projects can make with small, subtle changes. The project supports the process of managing change by evaluating progress and analyzing changes after implementing to ensure effectiveness, such as evaluating the prior nurse-driven protocol and creating modifications to improve the outcomes. The cost to implement this project was minimal. The organization already had an EMR system and the nurse-driven protocol intervention was in effect. Only edits to the current nurse-driven protocol intervention were completed during the project. The small changes implemented by the project exemplify impacts to healthcare policy and reforms how indwelling catheters are utilized in the acute care setting. Recommendations for practice and future research should ensure the nurse-driven protocol intervention is arranged to achieve the desired outcomes and obtain the organization's goals. Any limitation to the project's goals, such as the facility's inappropriate indication to not remove an indwelling catheter for altered mental status, should be removed. Altered mental status is not an approved indication to maintain an indwelling catheter. Orders should limit utilization to specific indications by requiring selection of an approved indication upon ordering. Verbiage for promoting alternative methods and avoiding indwelling catheter placement should be included in both the intervention and the order. The intervention should encourage frequent reassessment of appropriate indications by nursing staff on every shift. The time interval between reassessments has not been studied in the literature, so there's no formal recommendation, but once a day at 6 a.m. is not effective. Documentation by nursing staff should be monitored in real time, not as a retrospective audit. Real-time monitoring would allow for immediate correction and education to improve outcomes. One area of improvement that this project highlighted was the need for post-removal protocol or an algorithm. The project also highlighted the importance of disseminating evidence and education to all departments that impact the study. After all, 33 to 40% of our indwelling catheters were placed before the patient arrived to us. Future research should focus on creating a critical care culture where indwelling catheters are the exception, not the expectation. The interventional edits to the current nurse-driven protocol effectively reduce the utilization and duration of indwelling urinary catheters within the critically ill population, although statistical significance did vary. The organization was able to improve benchmark values to comparable values of other organizations within the region. Clearly defining criteria for critical care use eliminated barriers, challenged the traditional culture of the critical care unit, and provided future options for improvement. Creating and implementing this project through the DNP program has been an amazing experience. I've had lots of fun and have learned so much by doing this project. It has excited a fire in me. I plan to continue working on this particular project with the recommended improvements and am already planning on my next project once graduation is over. Keep a lookout for me. I am off to do great things for our patients. Any questions? These are my references. Thank you for listening to my presentation.